will be the second in this, and it's one of the programs put in place by the Transplant Advocacy Committee of AFRAN. And the plan is to have these sessions every single month. And this will be the second in the series. Today, I would be moderating the session. My name is Ebun Bangboe from Lagos. And the topic that we're scheduled to discuss today would be HIV and kidney transplantation, the past, the present, and future days and beyond. We're fortunate enough to have someone who is quite experienced in this topic. And our speaker today will be Professor Graham Paget. Professor Graham Paget is the head of the renal division of the Charlotte Maxeke Johannesburg Academic Hospital in South Africa. He is the academic head of the nephrology unit in the University of Witwatersrand, and he was the head of that unit from 2013 to 2019. He is an adjunct professor of the university and has been that since the year 2014. He currently leads the Johannesburg Academic Nephrology Transplant Unit. He's actively involved in postgraduate training and has convened and examined for certificate in nephrology subspecialty exams for the Colleges of Medicine of South Africa. In that role, he has mentored many fellows in nephrology, including several ISN fellows sponsored from all over Africa. He's been a president of the South African Renal Society and was its president from 2016 to the year 2020. He has several research interests, but he particularly focuses on viral infections in renal diseases, particularly in transplantation. He's a fellow of the Royal College of Physicians in the UK. So we're extremely privileged to have somebody who is so experienced talking to us on a topic which many of us were involved in transplantation, which want to learn from the experience of such an experienced gentleman. A few housekeeping notes. First of all, to thank you for attending the webinar. Please note that you should try and join from a quiet, distraction-free zone. Ensure once you join that your microphone is muted and that your camera is turned off upon entry into the virtual meeting room. There'll be a chat box available, and I would request that if you have any comments or questions, please indicate them in the chat box. All questions will be taken from the chat box only. So without any further ado, I'd like to invite Professor Graham Paget to talk to us about HIV and kidney transplantation, the past, the present, and the future. Thank you. Professor Paget, over to you.
Good evening, all. Thank you to AFRAN for inviting me to discuss this topic with you. I take it that my talk can be seen and I can be heard. Is that correct?
Yes.
Okay, right. Then on we go. I hope I'm going to talk a little bit about our journey through HIV in the past, some of the experiences and challenges we've had, what we're sort of doing, and where we could go. Interestingly, there's no such thing as a good pandemic, I guess, but certainly I believe our experiences in the recent pandemic with COVID-19 are very much different from what we experienced in HIV, especially in the terms of the stigmatization of patients who acquired the HIV infection. So those of us that lived through it certainly saw the initial horror and fear around doing anything with HIV positive individuals to where we are today. So I hope you'll enjoy taking this journey with me and learn a few things along the way. I'm just going to, yeah, okay. So essentially the very first case report was around June in 1981, where the CDC in the US described cases of pneumocystis, which hadn't been seen in years, in 5 young, previously healthy homosexual men in Los Angeles. Interestingly, through that time, by 1998, in the US, the use of organs, and this is a direct quote, infected with the etiologic agent for AIDS was banned through what was then the National Organ Transplant Act. So all transplantation from anyone who was infected with what they weren't sure what was going on yet was not allowed to donate an organ. And HIV essentially stayed in this sort of subculture, almost so to speak, for a few years until a few notable celebrities announced their HIV infection. And this kind of brought HIV into the public sphere, and some of the myths around it were dispelled. So some of the famous ones, Magic Johnson in November 1991, and then also another famous celebrity, Freddie Mercury, who was the lead singer of the rock band Queen. He died of AIDS-related illnesses in the UK at the age of 45 at the end of November in 1991. In 1997, the initial highly antiretroviral therapies became the new standard of HIV care. They were nothing like they are now, but at least we had something. So in the pre-CART period, this is now in the US, so we're talking before 1996, Joan Trellis published a meta-analysis, and essentially what this did was it trashed, well, not deliberately, but it certainly trashed transplantation in any patients who were not on antiretroviral therapies. And if I draw your attention to this right-hand column here, you can essentially see that almost there were small numbers of transplants that happened, cadaver, some live donors, but almost universally, the transplants were associated with a fatal outcome. And this somewhat led to the 1997 declaration that transplant for HIV-infected individuals should not happen. And that's how things stayed for a while. Essentially, it was about a year later when antiretroviral therapy became more available for individuals with HIV infection, that there were some suggestions in the literature that HIV-positive individuals could be considered for transplant. And essentially, a survey, this was not a meta-analysis or anything, but this was a survey conducted amongst almost 250 renal transplant centers in the US. There were some interesting results. So about 2/3 of them had instituted mandatory testing for recipients. Before that, they hadn't. 84% would not transplant anyone who refused testing. 88% said they would not transplant a deceased donor kidney into an asymptomatic patient, and that 91% would not perform a live donor renal transplant into an asymptomatic patient. But really, in terms of walking the walk or talking the talk, no center had actually performed an HIV-positive transplant in the year before the survey. So essentially, transplant in terms of HIV in that era had ceased to exist. Dr. Halpern in 2002 published an opinion piece, and it was slightly controversial when he said, now is the time to remove barriers to transplantation in HIV-positive patients in whom it is otherwise indicated, and that we should not wait for evidence of efficacy to emerge. And he then went on to say, we have evidence of diminished survival amongst hepatitis C positive patients, patients with diabetes, Black patients, and patients requiring retransplantation. yet we do not prevent transplantation in these groups. So it was quite a strong statement saying, why do you have double standards? At the similar time, unfortunately, in South Africa, the president at the time, Thabo Mbeki, was part of the government's, the South African government's AIDS denialism. So this is, those of you who are South African will know Zapiro. He's a strong cartoonist with strong opinions. And interestingly, in this PhD student's PhD, it was estimated that because we didn't start ARVs early enough and we waited till at least 2005, that more than 330,000 lives, or approximately 2.2 million person years, were lost because the ARV program was not implemented. We also had at least 35,000 babies were born with HIV, which resulted in 1.6 million years lost by not implementing the pregnancy prophylaxis program with nevirapine. And the total lost benefits were at least 3.8 million years for the period 2000 to 2005. And this was somewhat of an indictment on the South African government, and certainly curtailed any efforts to have HIV positive individuals partake in transplant programs, but also very importantly in dialysis programs, because South Africa still has, and in those days, had implemented a policy of no dialysis if you were non-transplantable. So it always takes some, so Peter Stock is credited with being a pioneer in this field in San Francisco. And this is a pilot study published in Transplantation around about 2003. And what was interesting is that there was a mixture of ethnicities. The patients were fairly young. Many of the HIV positive individuals are young and fit. And for the first time, the patients were on ARVs, various combinations at the time that were available. There didn't seem to be a lot of rejections over the period of follow-up. And these are not SI units, but approximately if you multiply by about 80, 88, you will see that over the period of follow-up in this small group, this pilot study, sometimes for periods of up to 2 to 3 to even more years, that it seemed that these patients on ARVs did reasonably well. So this opened the door for further studies. And approximately 2 years later, Dr. Kumar published his results in around about 40 patients. The induction was basically IL-2 receptor blocker with steroid, cyclosporin, and rapamune. So no real antimetabolite as such, or rapamune technically is. But again, what was interesting was that the survival of these patients over the 2-year period of follow-up was not that bad. So approximately sort of 90% patient survival and about 70% graft survival. And if you actually look at why these patients died and lost grafts, I think you'll perhaps agree with me that these look like sort of ordinary causes of medical problems that happen post-transplantation, rather than opportunistic infections per se. So again, this was a study, a slightly bigger study, that then said, look, this looks certainly feasible. And then eventually the landmark article was published in the New England Journal, where essentially a large group, almost 100 patients in San Francisco, underwent renal transplantation while using antiretrovirals. And the results were then compared with the US renal transplant registry. And essentially what was found that was that although there were more episodes of rejection, the comparable survival of HIV-infected individuals in the study was better than 65-year-olds. And also in the graft survival was better than 65-year-olds, and not that far off the usual registry in the US. So this essentially gave a roadmap of how we should proceed. Interestingly, because the signal of rejection was there, more patients were given ATG. Initially, in the early phases, people were very afraid of it because the concern around opportunistic infections. But for the first time, we started to see that about half the patients had IL-2 receptor blockade, and at least a third were given lymphocyte depleting products. Also, tacrolimus was available at that time and was used now as the calcineurin inhibitor in 2/3, cyclosporin in about 25%, and almost 90% of the patients were now on mycophenolate. So this started to suggest that essentially usual induction immunosuppression for what might be termed high-risk individuals was effective and not associated with poorer outcomes in HIV-positive individuals. ARVs were non-nucleoside reverse transcriptase inhibitor based in about 40%. Protease inhibitors were used in 40%, and a lesser percent used combinations. Also, in this study, they had decided that patients should be transplanted when their CD4 counts were more than 200, and also that they should be virally suppressed. And this still stands today in many OPOs. So again, acute allograft rejection rates were higher than the SRTR registry, so we needed to be aware of that. And of those over 100 patients, 5 developed opportunistic infections and cancers: Kaposi's, pneumocystis, Candida, and Cryptosporidium. And interestingly, it looked like only 2 patients over the period of follow-up developed HIV-associated nephropathy in the new kidney. Importantly, if you gave patients ATG, you needed to be aware that the CD4 counts would drop quite substantially more than using IL-2 receptor blockade, so 238 versus 135 cells per mil. And once again, when you did this, though, of the 150 recipients, about 40% of them had a total of 140 reported infections that required hospitalization. So in other words, by upping the immunosuppression to counter rejection, you needed to be aware that these patients may develop more infections than you might expect. However, to reiterate, survival was equivalent. So essentially, our Renal Society in 2008 issued a statement, which then was actually incorporated into not quite regulations, but into a guideline signed by the then Minister of Health approximately 2 years later. So the Renal Society, basically using the stock study, said that all HIV patients should be considered for dialysis and transplantation and therefore renal replacement therapy. They should be on antiretrovirals for at least 6 months. They should show a commitment to therapy and be compliant. The CD4 count should be more than 200. The viral load should be okay. No active opportunistic infections, but we would treat patients with like tuberculosis. Importantly, certain opportunistic infections were a problem, like cryptococcal meningitis, for example, is perhaps a big no-no. There should be no history of malignancies, ideally, but if pretty much as the Israel Penge registry says, if they'd had a previous solid tumor, they may be considered. And then certain HIV-related conditions specific to HIV. So PML, because of its poor outcome, HHVH-associated lymphoproliferative disorders like multicentric Castleman's, visceral Kaposi's, and certainly in terms of oncogenic viruses, papillomavirus, cervical or anal intraepithelial neoplasias or carcinomas in situ should at least be addressed. So we still look at that because we do have high rates of cervical carcinoma in South Africa. So one of the meta-analysis that then even solidified what we would then do for these HIV positive individuals was again published by Dr. Trellis, who, remember, sort of several years before had basically said this is horrendous to try and do. But now, so just to draw your attention to the left, basically what happened here is that these are the recommendations that we still perhaps use even today. So you should use 2 NLTIs like tenofovir. and emtricitabine or 3-TC could be used and dose adjusted to renal function. Tenofovir could be used. We are aware of potential renal toxicity, but as long as you watch that, bacavir can also be used, and we certainly use it, provided you've just excluded the B5701 hypersensitivity SNPs. Protease inhibitors, again, this was one of the first studies that said that there are important interactions with the immunosuppressive drugs, particularly the calcineurin inhibitors and protease inhibitors. And we are talking significant reactions. Importantly as well, we are now certainly in South Africa in the era of integrase inhibitors. And what was even known as far back as 2010 is that these seem to be the perfect drugs for renal transplantation. They are highly efficacious. They have virtually no reactions, and almost virtually no interactions with the immunosuppressive drugs. So this led, or we are slowly leading into what became standard of care for patients with HIV. So this is just to thank Dr. De Wael, who did this, audit for us. This is a few years ago, but just to show you, at Charlotte Macheke, we've had some HIV positive individuals. Rather sadly, in the early days, we had a few patients acquire HIV post-transplant, and certainly now counseling as regards sexual health and sexual safety is now a very important part of what we do when we transplant young individuals, or anybody really. One shouldn't always judge. But just to highlight a couple of things. If you look at the periods of follow-up, so 16 years, sometimes a good 5-6 years, you'll notice that the renal function is actually quite reasonable. 1 or 2 patients demised. Unfortunately, some were non-compliant, some did develop. But realistically, the infections were not particularly strange in terms of renal transplantation. Okay, 1 PCP, fair enough. But a lot of them were UTIs, which is the kind of thing that you would see. You do see rejections, but you see rejections in non-HIV individuals anyway. And the survival rates, unfortunately, graft loss in South Africa does sometimes translate into no dialysis. So that does skew the data. But again, in our relatively small local experience, this looks very similar to what many of the transplant outcomes would be, at least in my view. So then on to what really put South Africa on the map in terms of HIV transplantation. And this is Professor Miller from Cape Town. She's now at Stellenbosch, but in those days was at UCT, but it's still the Cape, so it's okay. And she proposed what was left many aghast, which was to think about South Africa. We were the epicenter, one of the epicenters of the pandemic. We had the most people living with HIV. We had we still have a 2-tier health system where a lot of the poorest individuals would have HIV, but be unable to access renal replacement therapy. We'll talk a little bit about rates of HIVAN, et cetera, a bit later. It's not really the focus of the talk, but essentially we had a lot of people with HIV who couldn't necessarily always access dialysis. So why wouldn't we use HIV positive deceased donors to HIV positive recipients, and in studies see how they would do? And we know that the prevalence of chronic kidney disease amongst HIV individuals, even on ARVs, was between 8 and 22%. So it certainly looked like it was a worthwhile endeavor to do this. I know she got a fair bit of backlash around this, but I mean, hats off to her, she stuck to her guns. And it was a few years later that she then published the 5-year follow-up, 3 to 5 year follow-up data on these patients. Just to draw your attention to a couple of things again. So in terms of the Kaplan-Meier survivals, once again, almost up to 5 years. So up to 85% graft survival, 80% patient survival. Again, very comparable to programs around renal transplantation. particularly when one considers that most of the patients were of Black African descent. So one should compare the outcomes to, say, for example, African Americans, if you can. So, you know, certainly good survivals. Causes of chronic kidney disease. And again, note that the CD4 counts generally above 200. Importantly, they tended to use lymphocyte depletion exclusively. So HIV positive individuals were all induced with lymphocyte depleting antibody therapy. There were also quite a few of them on protease inhibitor based therapy with dose adjustments, which I'll show you now. So importantly, just to highlight, so only a few patients at 5 years of follow-up had a rejection episodes. Most were treated with methylprednisone, and most were left with a functioning graft. Only one donor, importantly, so initially there was a fear of superinfection or with ART-resistant strains of the virus. So many of the donors originally were excluded if they had been on ART. So most of the donors were ARV naive. But overall, the risk of superinfection was not found to be an issue. Viral loads have remained suppressed. The median tacrolimus level was unbelievable. To maintain a trough of 6 to 8 was 0.5 milligram almost every 2 weeks on patients on PIs. So this is an important thing. So be very careful of calcineurin inhibitors with protease inhibitors. 5 patients had actually evidence of protease inhibitor in presumably assisted calcineurin toxicity, and 3 patients had developed early changes of HIVAN not seen on early histology, but very similar to the original studies, which showed that recurrent HIVAN was not a big problem. And we know that with effective ARVs, even nowadays in non-transplant individuals, that you're not seeing a lot of HIVAN. We really aren't. So Professor Muller's study is actually credited with being one of the turning points for the HOPE Act in the US. So the HOPE Act repealed the transplant of organs from HIV positive individuals to HIV positive individuals in 2013. President Obama signed it into law. And the quote was, although clinical experience is limited to a small number, unprecedented and HIV liver transplants and living donor kidney transplants are now also on the horizon. So this is us moving forward, looking at HIV, what can we do? And certainly it seemed that HIV positive to HIV positive individuals was reasonable and opened the door for some of the things I'm going to discuss. So talking about the future. So what about now taking kidneys from HIV positive live donors, right? So this is an interesting idea. It has been done. You will not find a lot of case reports on this. People are quite worried about it. So this is in Eastern Europe. This was a 41-year-old Caucasian who wanted to give a kidney to her husband. Her CD4 count was good. She had undetectable viral load. And this was the, if you notice, this is a 7-year follow-up on this donor. She has a normal creatinine, EGFR is excellent, and essentially there's been no impact on her natural history of either her renal single kidney or her HIV. So I love the title, In Sickness and in Health. This is properly how to support a marriage, I would say. So now, before we all rush off and start enlisting our patients as donors, bear in mind this was a Caucasian donor. So just a cautionary note. So this is work from Alex Kesembeli at Wits with Professor Naika. And essentially, so I'm sure most of you are familiar with the impact of APA-L variants. So the so-called Tworisk allele, so G2, it's the easiest way to remember, it's called G2. We have a population incidence of these G2 alleles, according to Dr. Kesembeli's study, of around 11%. Importantly, though, if you were HIV positive, and you had a combination of G2, or you were G2, 2 risk alleles, your odds ratio was something like 90-fold higher than the HIV negative patients and controls for developing HIV-associated nephropathy. So this is something to think about before you say an HIV positive individual can give, well, put it this way, a Black African HIV positive individual can give a kidney to a recipient of their choice. So it's just to highlight that, where the jury's still out. We'll talk a little bit about it now. So how do recipients do with APA-L1 risk alleles? So again, there is not a lot of data around this. And essentially, this is a post hoc analysis of 2 studies. The one is a genomic study with patients who had acute rejection, and the other is a clinical transplant study. And this group basically analyzed the death-censored allograft survival for recipients with different numbers of APA-L1 risk alleles. Important to note is they made some assumptions. They made some assumptions about ethnicity from demographic data. So again, we're not saying that you can't do this, but there's a little signal that we just need to be a bit careful. And you'll notice that in terms of rejection, they were actually able to show that patients with G2 had more activation of T cells and NK cells. So graft loss due to rejection was higher in those with G2 than G1 or G0. And importantly, even in the clinical studies, again, although not quite as significant as in the genomic study, but again, a significant risk of potential graft loss with APA-L1 risk alleles. So what about donors? So donors who are HIV positive, who wish to give an organ, well, a kidney, shall I say, to a recipient of their choice, there's actually only one real study, or one very small study that's looked at this in 2018, published by Doshi. This is from this article in APA-L1, published in June of 2019. So not a lot of work's gone into this. But essentially, of 19 patients who had 2 risk alleles, this is donors, the development of the odds ratio for ESRD with the 2 risk alleles was 30-fold higher than the controls. So again, a cautionary note around this. And just to be aware, there's the Apollo study, which is ongoing in the US. It's a 13-center study looking with OPOs and genotyping centers, and it will actually attempt to prospectively obtain APA-L1 genotype data for donors and recipients. So currently, there's a bit of caution to be exercised in demanding APA-L1 testing for recipients and donors, but certainly it is something we have in our armamentarium going forward. So it is something to think about. So now, really pushing the envelope. Now, what about transplanting organs from someone who is HIV positive to someone who is HIV negative? It has been done. The first case was at Donald Gordon, the Wits University Donald Gordon Medical Center in Johannesburg under Professor Botha. This was a liver, and the difference here is obviously that there is no alternative therapy for acute liver failure realistically other than a liver transplant. So perhaps not quite as urgent as, say, for example, renal failure if you have dialysis, but still interesting. So a mother, HIV-infected mother, who was virally suppressed with on ARVs with a CD4 count above 200, gave a segment of liver or half a liver to her child who was in acute, in end-stage liver failure. And importantly, we know that about 20% of children who were listed actually die on the waiting list. So they don't actually get an organ in time. So the recipient was started basically on ARVs, even though she was, or the recipient was HIV negative in the evening before, to reduce the risk of acquisition. So both remain on ARVs. The recipient was seropositive at 49 days post-transplant, and then antibody levels have declined to near undetectable, and the viral load remains undetectable. So what is interesting is the recipient HIV positive or not? And we're not really sure. So you can't convincingly determine the HIV status of an uninfected recipient from an HIV virally suppressed donor. And this because you may be picking up maternal antibodies, you alter antibody responses with immunosuppression. What does very early antiretroviral therapy do? And it's possible that seroconversion that was seen was driven by maternal immune cells resident in the allograft. So there are many questions here, but this is a very interesting case in terms of what actually happens. So we've certainly had patients on the dialysis list who have intermittently had ELISA positive, and we've never managed to document viral load. And quite interesting, in at least 2 cases, when we performed the transplantation and watched the viral loads, they rose. So the patient was in fact HIV positive. Happily, it had no issue because the ARVs are so effective. And we're almost at the end, just to talk a little bit about ARVs. The talk's not so much about ARVs, but bearing in mind, we now are in an era where we have really highly, one can even say higher than highly effective antiretrovirals. So the combination, the South African combination of tenofovir, emtricitabine or lamivudine, and particularly dolutegravir, the integrase inhibitor, has basically meant that you can control HIV almost with your eyes shut. So it's easy to use. And what's happened now is we have created a big problem for ourselves. And this is going to be perhaps the next challenge in HIV positive transplants or HIV individuals. And this is weight gain and the metabolic syndrome. So the better ARVs, dolutegravir, TAF as opposed to TDF, so less renal toxicity, fairly costly but lower dose and highly effective. So TAF, PIs not so much, but our mainstay of therapy, integrase inhibitors and TAF, are now associated with, on average, over a 10% weight loss. And this is particularly evident in South African Black females. And also if you started out your ART career with low CD4 counts. So although these drugs are fantastic for control of antiretroviral or control of HIV virus, even with immunosuppression on board, we're going to have to look out for this issue, which is going to become a big problem for renal transplants. It's in the interest of time, I didn't really show you, but there are aspects of this which are important in terms of diabetogenesis, hypertension, cardiovascular risks. So this is going to be something not so bright in the future, but hopefully the clever people who make ARVs will sort of look at this. So in actual fact, some of the HIV positive individuals in our setting are actually refusing to be switched to things like dolutegravir because their friends told them that you're going to gain an enormous amount of weight. So just in conclusion, I would say that transplantation in HIV-infected individuals who are well controlled on ART is associated with equivalent outcomes to those who are HIV negative. With antiretroviral therapies, it is quite reasonable to transplant organs from positive to positive persons. We need to be a little bit cautious with HIV positive live donors of African origin. I think we just need to be aware of it. And then importantly, a role for positive to negative transplants, a little bit wild, but essentially in South Africa, remember that a lack of dialysis is equal to death for many with transplant the only option. So it's maybe not as nuts as it sounds. And on that note, I'd like to say thank you for your attention, and I hope you enjoyed the talk.
Well, thank you very much, Professor Paget, for an extremely simple, easy to follow, and excellent talk delivered precisely. I'm sure everyone who has attended has followed and benefited from it. I had indicated at the beginning that questions would need to be written in the chat box. So far, I haven't seen any. I think that's a reflection of how well and how excellently you have delivered the lecture. But I'll just ask a few questions, pending when we see any. What has been your experience with hepatitis C virus co-infections with HIV in transplant patients?
Right, so we actually have very limited experience with that. So the main reason is that realistically, in the essential medicines list in South Africa, the analogs for Hep C are not currently on the essential medicines list. So what it means is that the state is not obliged to provide analogs for hepatitis C. So, and certainly if any of you have ever used peg interferon for hepatitis C, you would know that in a renal transplant setting, it's a disaster. You tend to induce rejection, horrible drug, lots of side effects. So we've had a little bit of experience with Hep C per se, and to be honest, the outcomes weren't great. So the immunosuppression we use is quite potent. I mean, we use basically either IL-2 receptor induction or ATG induction, as well as we tend to use mycophenolate tacrolimus. So this is quite potent immunosuppression. The other aspect is that hepatitis C, for whatever reason, is not very common in South Africa. We're not sure why. We don't seem to have a lot of intravenous drug users. We as a population tend to smoke our drugs. So that perhaps helps a little bit, I don't know. But we don't, strangely, we don't see as many Hep C positive individuals as one might expect. So our experience, unfortunately, with Hep C and HIV is actually very limited.
Okay, thank you. Still no questions. Maybe I should just ask another one of mine.
Sure.
One concern had always been, in transplanting from an HIV positive donor, that even though the individual might have been controlled on the highly active antiretrovirals, was the risk that you might transmit a different strain, particularly a strain that might be resistant to the commonly available medications?
Yeah. So there's two aspects to that. The first is that, so if you look at Professor Miller's study, the 5-year follow-up did not show that, although admittedly most of the patients were ARV naive. But to be honest, in the era of NNRTIs and integrase inhibitors, really, I was listening to Francois Fenter's talk the other week, and essentially they are so effective now that if the only way you get viral resistance is if you don't take your tablets. That is how confident they are in the efficacy of these ARVs. So they are brilliant at viral control. We're going to have to deal with the metabolic side effects going forward. We're going to, it's coming. I can see it. We've got a different sort of pandemic on the way. But realistically, with the ARVs we have now, the possibilities, to be honest, I don't think you have to worry about viral resistance. I don't think you even have to think about it. Okay.
Okay, still no question. Well, I think there might be one.
Yeah, there might be.
Any quality of life? Are there any quality of life studies?
Yeah.
HIV patients who have received transplants?
To be honest, I don't know. I didn't look at it. I can only tell you just from our local experience, that we've had no issues with any aspects of the patients. You know, the patients who come to the program tend to be almost pre-selected. They are compliant anyway. They are used to taking medications anyway. They are used to side effects. They are used to having tests. They are used to these things. When you transplant them, it really is just a little kind of an upgrade for a lot of these patients. They actually take it very much in their stride. So it's not I don't think it's, certainly our experience is that they are as grateful and compliant and reasonably easy to manage as any other transplant individual. They are no different in my experience at all. But yeah, in terms of formal quality of life studies, to be honest, I didn't look. Sorry. Okay. But a very good question, very good question.
Two other quick questions, which I'll ask you to just take together. I mean, once you've done the transplants, how often would you, I mean, from your practice, how often do you do the CD4 and viral loads? And the second one would be from your experience as well, particularly if you use the PIs and the NNRTIs, and you use either cyclosporin or tacrolimus, how does that affect the dosing schedule?
Yep.
You had to do in both instances.
Yeah. So generally speaking, viral loads and CD4 counts will be done on a 3-monthly basis. We have a gatekeeping system in the hospital. So to cut costs, you're not allowed to do viral loads whenever you like. So you can only submit. And we haven't, to be honest, again, this idea that the new antiretrovirals, they really are highly effective. So certainly if you're admitted with something that's a bit strange, you know, you've got tuberculosis or possibly an opportunistic infection, which we don't see a lot of, we will check. But realistically, we follow the same guidelines, or we follow the same stipulations in terms of follow-up as standard treatment. In terms of CNI inhibitors, we don't use a lot of cyclosporin anymore. So predominantly we use tacrolimus. And realistically, the standard dose that we use for most patients on PIs is essentially 0.5 milligram every 2 weeks. And there was a suggestion at one time to actually cut costs, that we should put everybody on PIs, use so little tacrolimus. But I think that's pushing your luck a little bit, I think. But I mean, you know, it's much more effective than ketoconazole or fluconazole or calcium channel blockers, etc., in terms of allowing you to use less tacrolimus. I mean, the doses are, you have to be extremely careful with PIs. So it also gets a little bit complicated if patients end up on anti-TB drugs, because remember, rifampicin will sort of counteract. So we've certainly had the experience where patients have been on PIs or they've been switched by an ARV clinic. We didn't know about it, and we've seen tacrolimus levels of like 70, 80, unbelievable levels. So these are the sort of levels that you will see if you don't dose adjust. So again, it's about patient education. So you have to tell them, okay, right, you're HIV positive, these are your ARVs currently, but if you ever change, you must come to us and tell us. It's really, really important. You know, that again, it's, but once you're used to it, it's actually not difficult to do, to be honest.
There's another question in the charts. It says, Prof, for this talk, do HIV patients routinely qualify for dialysis in South Africa? Thinking forward, if HIV to HIV kidney transplants gain momentum, will they be readily taken over onto the dialysis programs?
Right. So HIV that is controlled, so in other words, you've been on ARVs for 6 months, you have a CD4 count that is above 200, although that's not cast in stone. As we know, there are many factors that influence CD4 count. So we will take patients whose CD4 counts are 150. What is important as well is you must not have those HIV defining or those particular like PML, Cryptococcus, things like that. Certain malignancies, you know, visceral KS, those sort of things. But other than that, if you've been compliant, etc., you have exactly the same chance as anyone else. So there's no difference. So the biggest limitation to being on dialysis in South Africa is not HIV. It's actually the number of slots, and it's the number of transplants that we do, which unfortunately has taken a huge knock because of COVID-19. It has really hurt us. Again, you know, this is the last thing we needed. So one of the knock-on effects of COVID has been a number of deaths of patients who do not get onto dialysis programs because we have not been transplanted. So we are restricted by budgets. Actually, we are restricted more by budgets than actual selection criteria. So most dialysis units in South Africa will have a waiting list of people who are definitely transplantable, who will die on that waiting list without getting dialysis. Unfortunately, I think this is the experience of many of our colleagues in Africa. I think it's, you know, we'd love to have the funding, we'd love to, but I understand, you know, there are competing needs, etc. So certainly, maybe this idea that we broaden the horizons and we start saying, well, because we have such good ARVs, let's take your HIV positive brother, and if he's willing to give a kidney, let's look at the Apollo study. Let's see what it's going to tell us about APA-L1 variants. Should we be testing them in? Are we doing a disservice to someone who's HIV positive by taking their kidney? You know, let's wait for those results. But you know, hopefully not too long. Remember that although it's nice to look at one side of the story, you're not seeing the other side of the story where it's definite. If you don't get dialysis, you die. So, you know, distributive justice, maybe we should look at it. It's interesting.
Thank you. Thank you so much, Professor Paget. I think we're just about an hour from when we started. I don't see any further questions, but
okay.
Initially, I think it was such an excellent talk that I think there was no real reason for anyone to ask any question.
Okay. No, that's quite fine by me. All right.
So I'd like to thank you. I know it's taken
thank you very much.
a bit of your time, but thank you so much.
Most welcome.
Being our speaker for this particular session. As I said at the beginning, and I'm speaking on behalf of the chair of the Transplant Advocacy Committee of AFRAN, Dr. Malcolm Davis, that this is scheduled to be a monthly series of webinars, and certainly would get across to you all to let you know when the next one would be and what the topic is.
Okay.
I think we should all say thank you very much, Professor Paget. And thank you to everyone who's joined in. Thank you to Lefi for putting this together. Have a good evening, everybody.
You too, sir. Good evening, everybody. Thank you. Bye-bye.